Hi, my name is Travis McVeigh. I'm an anesthesiologist from Dallas, Texas. I host a podcast called Thank You Notes at Ars Longa Media. Showing gratitude to people just makes me feel good, and I want to share the practice of thank you notes with everybody who listens. I write thank you notes to people and then bring them on the show to read it to them. Past guests have included my high school teachers, my friends, other physicians, and a couple of internet celebrities. I will also be doing episodes that explore the science behind gratitude practices to demonstrate to everybody the actual tangible benefits of practicing gratitude. Listen everywhere you get podcasts and check out the extras on my social media accounts. Thank you for listening.
The Study Smarter series, and this message is brought to you by StatMed Learning. You ever wonder why you do volumes and volumes and volumes of questions, but your average doesn't seem to improve? Well, stay tuned to hear from Ryan Orwig, founder of the STAT program, on how you can improve this and get better with our StatMed lesson. And now, let's get into the show.
Illness is not an indulgence which you should pay for, nor is it a crime for which you should be punished. But this conviction of the danger of my health. Shut it! Right. Just cause you break bridges and must obey. No, you won't see us participating in that game. Keep it twisted, take on success. Cause all I really want is what's beating in your chest. Doctor, let's see your knees to test.
Welcome to the Inside the Boards podcast, the podcast dedicated to helping you learn to think like a question writer so you can study smarter, not harder, and succeed in medical school.
Welcome to the Inside the Boards podcast Study Smarter series. I am Patrick Beeman, your host. Before we get into the second part of our biochemistry discussion, focused this time on collagen vascular disease, I wanted to take a moment to really make an appeal to you from my heart. Since everyone is gearing up for boards, I wanted to take the time to ask for a favor. And I know we ask kind of a lot of favors, and we really are thankful for those of you that have supported us with reviews, ratings, likes, and sharing us on social media. But even still, there are a lot of medical students that just don't know that we are a free resource sitting on their phone that they could take advantage of when they aren't actively studying. We think those students should hear about us, and because of that, we're starting up the ITB Ambassador Program. If you check out the show notes, you'll find a link to a simple form where you can get involved. And I know what you're saying, I don't have time for this right now. I'm a medical student who's setting up for my board exam, but trust me, we know, so here's the deal. You sign up now and do one simple task for us, which we'll send to you in an email. We won't bother you again until you're over the hump. This will take maybe 5 to 10 minutes of your time at most. And since you're probably going to want something to listen to while studying for your boards, we will give you a free subscription of at least 3 months to our Step 1 All Audio QBank. So if you're the first person from your school, I repeat, if you are the first person from your school to sign up and do this one simple task for us related to social media and getting the word out, we will give you at least a 3-month free subscription to our Step 1 All Audio Question Bank. We can't run this deal forever, so whoever joins between now and the end of the month of April 2018 is going to be eligible. If you're listening to this later, on the other hand, no worries. Still sign up, and we will give you first dibs later on when we try something similar. Thank you for listening. Thank you for sharing us. Thank you for supporting the Inside the Boards podcast. Now, let's get to the show. All right, we're back with another StatMed lesson with Ryan Orwig, founder of the statprogram.com. You can get a special offer just for ITB listeners and learn more about what Ryan's doing to help students by going to the statprogram.com/ITB. Ryan, the problem with doing volumes of questions but not improving seems universal. I hear it a lot. Students are like, I did UWorld, I did USMLE-RX, I did Kaplan, I did like 6,000 questions, but my average percentage stays the same. I can't get any better. What's the reason for this?
I think the conventional wisdom for boards prep is to do, like you just said, volumes and volumes and volumes of questions. That might be a combo of tutor mode, test mode, I don't know. That does seem to work for most USMLE and COMLEX students. But I don't know what most means. Are we talking 95%? I don't think so. 55%? Probably more than that. Somewhere in between. It works. But what if it's not working for you? What if you're one of those med students who are sort of in this perpetual cycle? And I think that that's sort of the wisdom that you'll find online. That's the accepted wisdom and advice from deans. But I don't like it. I don't think that the feedback is precise enough. So let's think about it like this. I think if I put a video camera on a student doing a timed practice test, what data is that going to give me? Apart from a raw score, it would tell me three things: how long they're spending per question, how fidgety they are, and if they concretely, physically change their answer. Like they click on A, then like, no, let me click on B. To me, that data is extremely superficial. And for what we want with stat med, ultimately, that's useless. It's useless for systemically changing process. That's too superficial. We want to dive down underneath the surface. Okay. So if picking C is their decision, click, I pick C, I'm done, I miss it, or I get it right. I'm more interested in what steps are being taken en route to making that decision. That's what we call the micro decisions. What micro decisions did they sort of make and go through en route to choosing C? What clues were they using from the passage? Did they use the right ones, or did they not use the right clues? Did they twist a clue to make it fit a desired diagnosis? Did they make a prediction that biased them? Did they sloppily read and weigh the answer options? Did they freak out because they didn't know 100% what the answer was? I mean, there are so many possibilities here. So whatever awareness students might have of those so-called micro decisions in the moment, I think some students might have awareness. Some of them don't even have an awareness. It's so staticky and chaotic while they're in the question. Regardless, the specifics of that awareness is certainly gone for the ages shortly thereafter. So that's what we want to change with the StatMed Boards workshop. That's exactly what the workshop does. The process teaches students a way that's going to make them explicitly aware of and accountable for those micro decisions. Really, the heart of the StatMed process itself creates a detailed record of those micro decisions. We use that as the feedback loop to change their test taking behavior.
To learn more, go to thestatprogram.com/ITB.
So next question here. A 30-year-old man comes to the clinic because of difficulty swallowing for the past week. Physical examination shows he is thin and tall in stature with long, skinny fingers. A barium swallow yields a colon with
multiple diverticula?
Numerous diverticuli. The mutation of which of the following genes is most closely associated with this patient's condition? Is it A, the FBN1 mutation, B, the MYC gene mutation, C, the RET gene mutation, or D, the P53 gene mutation? All right, what are we thinking here, Patrick?
Well, when I read this vignette, the first thing I think is, okay, they said tall, thin, long, skinny fingers. This person almost certainly has Marfan syndrome or a Marfanoid body havis. Maybe they have homocystinuria. So I'd go with FBN1 mutation because I'm pretty sure that's associated with Marfan.
Right, and you would be correct for making that leap. Oh, I don't know if it's a leap, but the answer is A, the FBN1 gene.
And that encodes the fibrillin-1 protein. And I guess how? So Marfan syndrome is a connective tissue disorder, but in my mind, I want to know why. Like, why does a mutation in fibrillin-1 cause diverticulosis in the colon?
Right. So, you think about fibrillin and it's a support protein.
I do not think about fibrillin ever.
So when you're studying for step 1
okay.
and you're thinking about the fibrillin-1 protein, you know that it's a connective tissue protein, right?
Yes.
That provides stability. The main function of it is to basically add support to elastin fibers as like a sheath process, right?
Yeah. See, that's what I was thinking, like elastin being problematic. So it's just a subcomponent of elastin.
Right. So if we've got a messed up encasing of the elastin, now we're going to allow for anything involving this collagen to be weakened and potentially create outpouchings. right?
Okay. Yeah, that makes sense.
Yeah, so the elastin microfibrils are important in connective tissue. They're abundant in, the body, but particularly where we see them are like large blood vessels, like the aorta. And then another one, classic with Marfan's, are the suspensory ligaments in the eye or the lens.
Okay. And specifically the upper portion of the lens, which is why you get the upward dislocation of the lens in Marfan's, right?
I think so, the subluxation.
Yeah.
And then another place that you might be able to attribute to Marfanoid habitus is it's common in the periosteum as well.
Okay. And that probably lengthens things somehow.
Yeah, well, it's allowing for the bone to continue to grow. There's not steady encasement of the bone. I'm sure that's probably more complicated than I'm describing it.
I'm sure it is too, but again, we go back to that. Relying on heuristics when you're dealing with or need to deal with, very complicated information.
Oh, yeah.
And as a reminder, the inheritance pattern for Marfan syndrome is autosomal dominant.
Right. So you could potentially even have a genetics question with this, where they're talking about, the father has trouble seeing and is really tall, and then this child is needing glasses really early, and one of their brothers, had heart failure at like a very young age kind of thing.
Yeah.
So going back to the image here, we have basically a colon with innumerable diverticuli, and this is because you don't have this fibrillin protecting the elastin. There's outpouching, as you might have in any, when there's excess pressure in the system, and these diverticuli get formed. It's the same way that you might have an aneurysm occurring in the aorta.
Okay. All right. Yeah, that kind of makes sense. I wish we just taught it this way instead of using all these scientific terms and fibrillins and elastins, and just break it down for me so I can remember it on a test. That's what I want.
Right. We're not really focusing on it. There are a couple other disorders that are really related to the diverticuli. Another good one is Ehlers-Danlos, since that's going to have this defect instead of the fibrillin. It's in the elastin. We're talking about Marfan's. And then another example is in scleroderma.
Okay, so scleroderma, Marfan syndrome, Ehlers-Danlos, you can bank on those having a higher incidence of multiple colonic diverticula.
Mm-hmm.
All right, let's move on. Let's do one more.
Yeah, sure. Okay, a 30-year-old woman who plays tennis presents in clinic for evaluation of her current shoulder subluxation. She reports that she's always been flexible and can hyperextend her knees and elbows. She has self-managed her shoulder issues until now, but she worries that they might shorten her career. In addition, she has noticed that her skin bruises and splits easily, taking a long time to heal. Friends comment that her skin is unusually stretchy, but she thinks that her skin type simply runs in the family. Which of the following cardiovascular findings is most likely to be present upon physical examination?
Let me just say, on the test, everybody's going to have these moments. You're going to read this and you're going to be so excited, right? You're like, sweet, this is Ehlers-Danlos for sure, right? And then you get that interrogatory. Which of the following cardiovascular findings is most likely to be present upon physical examination? So this is one reason why I think people probably should read the interrogatory first. If you don't have a system that you're applying, find yourself making dumb mistakes. In other words, when you go back to review the practice questions you've done, implement some system. An easy one is just to start with read the interrogatory first, then go back to the vignette looking for clues related to that interrogatory. And then if you can, don't spend a ton of time on it, but use the cover the answers test, which is a requirement of all good boards style questions, that if you cover the answers and all you have is the vignette and the interrogatory, you should be able to arrive at an answer, right? There should be enough information there. So I think this is helpful because let's say you do that and you get to, this is Ehlers-Danlos, and it's going to be which of the following cardiovascular findings. If you haven't looked at the answers yet, you don't know if they're going to be listing like various defects in parts of the heart or vessels, whether it's going to be a physical examination related cardiovascular finding. But if you can start formulating what that actually is, if you actually know, it can help, I think, prevent you from choosing a wrong option based on, I guess, reflex or a sense of urgency and need to move on. And it may help, if you can't narrow things down, to at least eliminate some of the answer choices. So
Right.
I hear Ehlers-Danlos, and I'm thinking, don't they have...
Prolapse mitral valve?
Yeah, mitral valve prolapse. Thank you. I was trying to remember what it was called. So that's as much knowledge as I have without looking at the answer choices. So then I'd be looking for mitral valve prolapse, and prior to even looking at those choices, I'm like, all I remember with mitral valve prolapse is something about a click, a mid-systolic click. I hope that's true. So answer choices here are, I'll let you go through them.
All right. So we have A, a continuous machine-like murmur. B, a crescendo late systolic murmur with a mid-systolic click. C, a crescendo decrescendo systolic ejection murmur that radiates to the carotids. Or D, a high-pitched holosystolic murmur that radiates to the axilla.
All right. See, I would go just based on mid-systolic click, answer B.
Oh, yeah.
All right. So that's the correct answer? It is.
You would be right.
All right. So this brings up all this sort of why questions that I have in my mind that really perplex me as like a first-year medical student. I wanted to be able to be able then to explain why you get a mid-systolic click and why it sounds like crescendoing murmur in late systole. I don't think I could do that now. And maybe if I really tried to like think through that. But I guess what is important to say is sometimes you don't necessarily need that level of knowledge, right? You can arrive at the answer depending on how difficult the question is constructed without having all the information or knowing everything about this particular condition. Now, if you had a bunch of answer choices that also had included a mid-systolic click, I would have been a little sad because then I would not have been able to have helped myself all that much.
Right.
So unless you're able to do that, can you help me think of this like a second-year medical student?
Oh, I mean, I'm going along the same kind of route that you are. You know, I read this vignette, it screams Ehlers-Danlos, and I know that the mitral valve prolapse and aortic dilatation are two of the findings that you can have with Ehlers-Danlos. So I'm probably going to get to the answer choice here and be looking for those kinds of complications, right?
Yeah.
And unfortunately, this question it's not, you immediately are like, oh, mitral valve prolapse, mid-systolic click. And hopefully all of our listeners have that down too. But that actually brings up an extra order to this question, right?
Yeah.
Because you need to know that goes with our mitral valve prolapse. And it's probably a heuristic, but I basically think of the mitral valve is like a big parachute. And when the ventricle contracts, the high pressure sends the mitral valve up into the atria. And when it snaps open, it causes that click sound, right?
Sure. I would fixate on the like mid-systole portion, though, honestly, in that explanation. Like, it's a heuristic, so you can ignore portions of how you're remembering this, I think. But, like, why does it happen mid-systole? Because it takes just that long for the leaflets to go up into the atria or something.
First, you have to have your isovolumetric contraction. So the pressure has to get up high enough. And that takes a second, right?
I'd buy that. That sounds great. So there you have it. How to put this? A meandering way.
Oh, no, that doesn't work.
That doesn't work? All right,
No.
scratch that.
I'm trying to think how we could better describe that, right?
Well, actually, I would say this. As we go through these questions for the Study Smarter series this year, this is the exact type of feedback we would like to hear from you. In my mind, I don't think I'm being entirely crazy, but I think that there's a lot that I learned about taking exams and approaching questions as a question writer and editor, such that I don't worry so much nowadays. Well, obviously, because I don't have to take step one again. But also, like when I read these, I'm not so concerned with being able to understand and articulate all of the physiology. And is it helpful if I'm far away from step one to approach questions like that with Stuart? Or do you guys want us to be able to explain to you in terse, succinct ways the physiology or the questions that arise from our dissections of these questions? If it doesn't matter, don't send us any emails. If you have strong opinions, though, you would like the approach where we don't try to prep too much for these things and see if we can get to the answers without doing that. And when I say we, I mean mostly me, because Stuart is actually preparing for step one. But,
I'm going to prep. Yeah.
Yeah, he's going to prep. But if you like that kind of approach where we just see where we can get through reasoning and the elements of the question, that's kind of what I would favor. But if it is something that burns in your mind when you're done listening to a show and you really want a little more breadth of presentation, then please reach out to us at podcast@insidetheboards.com. All right. What else about Ehlers-Danlos? Sorry for that tangent.
Well, I think the vignette really highlights the basic findings. So the flexible joints, the
Stretchy skin.
very stretchy, thin skin, and fragility. So they even bruise easily. And I think the important part here is that it's a defect in collagen synthesis.
Mm-hmm.
This says here that it's a defect in collagen type 5.
But
however, it's also type 3.
Right. Yeah, exactly.
So I'm just going to avoid that a little bit here.
And probably because of the complexity of the genetics of Ehlers-Danlos, as well as the fact that it can affect either a lot or just a little, multiple different types of collagen, you're not going to be expected to memorize and know in detail all of the info related to each subtype of Ehlers-Danlos. In my mind, maybe you will be. I obviously I don't speak for the National Board of Medical Examiners, but in my mind as well, I'd be like, I will never be able to remember all that stuff, and I can't think of a way to learn it in a way that my understanding would help me reason through the various subtypes. It would be a matter of memorizing. This is a defect in collagen, 2 or 3 or 4 or 5.
Yeah, and I would be worried. Here again, I'm thinking I'm going to focus more on the elastin gene, the clinical findings, and the possible complications here, and less on the genetics, other than it's dealing with the collagen synthesis.
Okay, and I think that's like totally reasonable
and the boards
manageable.
are not. Oh yeah, that's definitely more manageable if you think about it that way. But I haven't really gotten a question that's asked me to delineate which of the collagens it is, and if it does, it doesn't include both. Does that make sense?
Yeah, yeah, and I think that's what the board, like, you may feel like you're being tricked on an exam, but you really aren't. These questions, as soon as you dispel that conviction from your mind, that I'm not being tricked, I think you can approach the test more on its terms. And it's still difficult, but the difficulty comes with the amount of information you need to know and the ability that you have to, differentiate similar things from one another. So that's Ehlers-Danlos, the classical type. There are a bunch of different types of Ehlers-Danlos syndrome which involve particular defects in collagen. It's probably not necessary to know exactly which type of collagen, because there are 13 types of Ehlers-Danlos syndrome, and some of them involve a defect of one kind or another in collagen 1, others in collagen 3, others in probably other collagen types, and hence too why collagen vascular disease is kind of a wastebasket category for all sorts of things. But I guess while we're on the subject, it probably is helpful to remember, if you don't already, a few high-yield facts about some of the collagens. So type 1 collagen, there's a defect there in which disease?
It's osteogenesis imperfecta.
Absolutely.
That's going to be with bones and tendons, right?
Yep. Brittle bones, autosomal dominant in most cases. Patients have multiple fractures with minimal force and classically that blue scleral hue due to the translucency of the connective tissue over the choroid with the deficient collagen. Type 2 collagen is spongy absorbed shock, so it's found in cartilage and the nucleus pulposus of the vertebral disc. I can't think of a particular syndrome that's a result of defective type 2, but I imagine that the pathophysiology of disc herniation or some like joint diseases that involve cartilage breakdown are a result of a type 2 collagen synthesis or a defect. Type 3 collagen, that's in the blood vessels and skin, like you mentioned, that its component is made up of reticulin, right? And defective type 3 collagen you see in forms of Ehlers-Danlos and associated with as well joint dislocation, barrianeurysms, organ ruptures. Type 4 collagen is the basement membrane stuff, which kidneys, that's a good place to think about it, or skin. So you can have defective type 4 collagen in Alport syndrome, which is a disease that causes both kidney disease, like hereditary, like a progressive nephritis and deafness. That's how I remember Alport.
And blindness, I think.
And blindness. Okay. And that makes sense.
Poor vision.
Yes. Visual difficulties. And then Goodpaster's syndrome involves an autoantibody against type 4 collagen in the lungs and glomeruli. So that's why patients get the hemoptysis and glomerular nephritis. So, all right. Anything else about collagen, or should we just like get out of biochemistry and move on to something else?
Sure. Yeah, I think we've hit it for, what it's worth.
All right. Well, you can get more high-yield questions in an audio format with the ITB All-Audio QBank. The Step 1 version of the product has content from both Osmosis and Lecturio. Just go to InsideTheBoards.com to learn more. And thank you for sharing the podcast and especially our Study Smarter series with your friends. And happy studying. Let us know how we can help you. Reach out to us, podcast@InsideTheBoards.com. Thanks, Stuart.
Thanks. See ya.
All right, that's it for biochemistry. I just wanted to say thank you to Rao Reynolds and Enter Shikari for letting us use the track Anesthetist off their album The Mind Suite. To hear some more of their music, go to entershikari.com or find them on Spotify or wherever you listen to music.